Concussion, from the Latin concutare or concussus, is the most common type of traumatic brain injury. The terms mild brain injury, mild traumatic brain injury, mild head injury, minor head trauma, and concussion may be used interchangeably, although the last is often treated as a narrower category. Although the term concussion is still used in sports literature as interchangeable with MHI or Mtbi, the general clinical medical literature now uses Mtbi instead. In this article, concussion and Mtbi are used interchangeably. Frequently defined as a head injury with a temporary loss of brain function, concussion causes a variety of physical, cognitive, and emotional symptoms, which may not be recognized if subtle. Treatment involves monitoring as well as physical and cognitive rest. Symptoms usually resolve within 3 weeks, though they may persist or complications may occur. Those who have had one concussion seem more susceptible to another, especially if the new injury occurs before symptoms from the previous concussion have completely resolved. There is also a negative progressive process in which smaller impacts cause the same symptom severity. Repeated concussions may increase the risk in later life for dementia, Parkinson's disease, and/or depression. A variety of signs accompany concussion, including somatic, cognitive, emotional, physical signs, behavioral changes, cognitive impairment, and/or sleep disturbances. Fewer than 10% of sports-related concussions among children are associated with loss of consciousness. Due to varying definitions and possible underreporting, the rate at which concussion occurs annually is not accurately known, but is estimated to be more than 6 per 1,000 people. Common causes include sports injuries, bicycle accidents, car accidents, and falls, the latter two being the most frequent causes among adults. In addition to a blow to the head, concussion may be caused by acceleration forces without a direct impact, and on the battlefield. Mtbi is a potential consequence of nearby explosions. It is not known whether the brain in concussion is structurally damaged or whether there is mainly a loss of function with only physiological changes. Cellular damage has reportedly been found in concussed brains, but it may have been due to artifacts from the studies. It is currently thought that structural and neuropsychiatric factors may both be responsible for the effects of concussion. Signs and symptoms. Concussion is associated with a variety of symptoms, which typically occur rapidly after the injury. Early symptoms usually subside within days or weeks. The number and type of symptoms any one individual suffers varies widely. Physical headache is the most common Mtbi symptom. Others include dizziness, vomiting, nausea, lack of motor coordination, difficulty balancing, or other problems with movement or sensation. Visual symptoms include light sensitivity, seeing bright lights, blurred vision, and double vision. Tinnitus, or a ringing in their ears, is also commonly reported. In 1 in about 70 concussions, concussive convulsions occur, but seizures that take place during or immediately after concussion are not post-traumatic seizures, and, unlike post-traumatic seizures, are not predictive of post-traumatic epilepsy, which requires some form of structural brain damage, not just a momentary disruption in normal brain functioning. Concussive convulsions are thought to result from temporary loss or inhibition of motor function, and are not associated either with epilepsy or with more serious structural damage. They are not associated with any particular sequelae, and have the same high rate of favorable outcomes as concussions without convulsions. Cognitive and emotional cognitive symptoms include confusion, disorientation, and difficulty focusing attention. Loss of consciousness may occur, but is not necessarily correlated with the severity of the concussion if it is brief. Post-traumatic amnesia, in which events following the injury cannot be recalled, is a hallmark of concussion. Confusion, another concussion hallmark, may be present immediately or may develop over several minutes. A person may repeat the same questions, be slow to respond to questions or directions, have a vacant stare, or have slurred or incoherent speech. Other Mtbi symptoms include changes in sleeping patterns and difficulty with reasoning, concentrating, and performing everyday activities. Concussion can result in changes in mood including crankiness, loss of interest in favorite activities or items, tearfulness, and displays of emotion that are inappropriate to the situation. Common symptoms in concussed children include restlessness, lethargy, and irritability. Mechanism. The brain is surrounded by cerebrospinal fluid, which protects it from light trauma, more severe impacts, or the forces associated with rapid acceleration, may not be absorbed by this cushion. Concussion may be caused by impact forces, in which the head strikes or is struck by something, or impulsive forces, in which the head moves without itself being subject to blunt trauma. Forces may cause linear, rotational, or angular movement of the brain, or a combination of them. In rotational movement, the head turns around its center of gravity, and in angular movement it turns on an axis not through its center of gravity. The amount of rotational force is thought to be the major component in concussion and its severity. Studies with athletes have shown that the amount of force and the location of the impact are not necessarily correlated with the severity of the concussion or its symptoms, and have called into question the threshold for concussion previously thought to exist at around 70 to 75 grams. The parts of the brain most affected by rotational forces are the midbrain and diencephalon. It is thought that the forces from the injury disrupt the normal cellular activities in the reticular activating system located in these areas, and that this disruption produces the loss of consciousness often seen in concussion. Other areas of the brain that may be affected include the upper part of the brain stem, the fornix, the corpus callosum, the temporal lobe, and the frontal lobe. Angular accelerations of 4,600, 5,900, or 7,900 radian per square second are estimated to have 25, 50, or 80% risk of Mtbi respectively. Pathophysiology. In both animals and humans, Mtbi can alter the brain's physiology for hours to years, setting into motion a variety of pathological events. As one example, in animal models, after an initial increase in glucose metabolism, there is a subsequent reduced metabolic state which may persist for up to 4 weeks after injury. Though these events are thought to interfere with neuronal and brain function, the metabolic processes that follow concussion are reversible in a large majority of affected brain cells. However, a few cells may die after the injury. Included in the cascade of events unleashed in the brain by concussion is impaired neurotransmission, loss of regulation of ions, deregulation of energy use and cellular metabolism, and a reduction in cerebral blood flow. Excitatory neurotransmitters, chemicals such as glutamate that serve to stimulate nerve cells, are released in excessive amounts. The resulting cellular excitation causes neurons to fire excessively. This creates an imbalance of ions such as potassium and calcium across the cell membranes of neurons. At the same time, cerebral blood flow is relatively reduced for unknown reasons, though the reduction in blood flow is not as severe as it is in ischemia. Thus cells get less glucose than they normally do, which causes an energy crisis. Concurrently with these processes, the activity of mitochondria may be reduced, which causes cells to rely on anaerobic metabolism to produce energy, increasing levels of the byproduct lactate. For a period of minutes to days after a concussion, the brain is especially vulnerable to changes in intracranial pressure, blood flow, and anoxia. According to studies performed on animals, large numbers of neurons can die during this period in response to slight, normally innocuous changes in blood flow. Concussion involves diffuse brain injury, meaning that the dysfunction occurs over a widespread area of the brain rather than in a particular spot. It is thought to be a milder type of diffuse axonal injury, because axons may be injured to a minor extent due to stretching. Animal studies in which primates were concussed have revealed damage to brain tissues such as small petechial hemorrhages and axonal injury. Axonal damage has been found in the brains of concussion sufferers who died from other causes, but inadequate blood flow to the brain due to other injuries may have contributed. Findings from a study of the brains of deceased NFL athletes who received concussions suggest that lasting damage is done by such injuries. This damage, the severity of which increases with the cumulative number of concussions sustained, can lead to a variety of other health issues. The debate over whether concussion is a functional or structural phenomenon is ongoing. Structural damage has been found in the mildly traumatically injured brains of animals, but it is not clear whether these findings would apply to humans. Such changes in brain structure could be responsible for certain symptoms such as visual disturbances, but other sets of symptoms, especially those of a psychological nature, are more likely to be caused by reversible pathophysiological changes in cellular function that occur after concussion, such as alterations in neurons' biochemistry. These reversible changes could also explain why dysfunction is frequently temporary. A task force of head injury experts called the Concussion in Sport Group met in 2001 and decided that concussion may result in neuropathological changes, but the acute clinical symptoms largely reflect a functional disturbance rather than structural injury. In summary, and extrapolating from animal studies, the pathology of a concussion seems to start with the disruption of the cell membrane of nerve cells. This results in a migration of potassium from within the cell into the extracellular space with subsequent release of glutamate, which potentiates further potassium shift, in turn resulting in depolarization and suppression of nerve activity. In an effort to restore ion balance, the sodium-potassium ion pumps increase activity, which results in excessive ATP consumption and glucose utilization. Lactate accumulates, but, paradoxically, cerebral blood flow decreases, which leads to a proposed energy crisis. After this increase in glucose metabolism, there is a subsequent lower metabolic state which may persist for up to 4 weeks after injury. A completely separate pathway involves a large amount of calcium accumulating in cells, which may impair oxidative metabolism and begin further biochemical pathways that result in cell death. Again, both of these main pathways have been established from animal studies, and the extent to which they apply to humans is still somewhat unclear. Diagnosis: head trauma recipients are initially assessed to exclude a more severe emergency, such as an intracranial hemorrhage. This includes the ABCs and stabilization of the cervical spine, which is assumed to be injured in any athlete who is found to be unconscious after head or neck injury. Indications that screening for more serious injury is needed include worsening of symptoms such as headache, persistent vomiting, increasing disorientation or a deteriorating level of consciousness, seizures, and unequal pupil size. Those with such symptoms, or those who are at higher risk for a more serious brain injury, may undergo brain imaging to detect lesions and are frequently observed for 24 to 48 hours. A brain CT or brain MRI should be avoided unless there are progressive neurological symptoms, focal neurological findings, or concern of skull fracture on exam. Diagnosis of Mtbi is based on physical and neurological examination findings, duration of unconsciousness and post-traumatic amnesia, and the Glasgow Coma Scale. Such tests may be administered hours, days, or weeks after the injury, or at different times to demonstrate any trend. Increasingly, athletes are also being tested pre-season to provide a baseline for comparison in the event of an injury. though this may not reduce risk or affect return to play. If the Glasgow Coma Scale is less than 15 at 2 hours, or less than 14 at any time, a CT is recommended. In addition, a CT scan is more likely to be performed if observation after discharge is not assured or intoxication is present. There is suspected increased risk for bleeding, aged greater than 60, or less than 16. Most concussions, without complication, cannot be detected with MRI or CT scans. However, changes have been reported on MRI and SPECT imaging in those with concussion and normal CT scans. And post-concussion syndrome may be associated with abnormalities visible on SPECT and PET scans. Mild head injury may or may not produce abnormal EEG readings. Concussion may be underdiagnosed because of the lack of the highly noticeable signs and symptoms, while athletes may minimize their injuries to remain in the competition. A retrospective survey in 2005 suggested that more than 88% of concussions are unrecognized. Diagnosis can be complex because concussion shares symptoms with other conditions. For example, post-concussion symptoms such as cognitive problems may be misattributed to brain injury when, in fact, due to post-traumatic stress disorder. Classification: no single definition of concussion, minor head injury, or mild traumatic brain injury is universally accepted. In 2001, the expert Concussion in Sport group of the First International Symposium on Concussion in Sport defined concussion as a complex pathophysiological process affecting the brain, induced by traumatic biomechanical forces. It was agreed that concussion typically involves temporary impairment of neurological function that heals by itself within time, and that neuroimaging normally shows no gross structural changes to the brain as the result of the condition. However, although no structural brain damage occurs according to the classic definition, some researches have included injuries in which structural damage has occurred, and the National Institute for Health in Clinical Excellence definition includes physiological or physical disruption in the brain's synapses. Also, by definition, concussion has historically involved a loss of consciousness. However, the definition has evolved over time to include a change in consciousness, such as amnesia, although controversy continues about whether the definition should include only those injuries in which loss of consciousness occurs. This debate resurfaces in some of the best-known concussion grading scales, in which those episodes involving loss of consciousness are graded as being more severe than those without. Definitions of mild traumatic brain injury were inconsistent until the World Health Organization's International Statistical Classification of Diseases and Related Health Problems provided a consistent, authoritative definition across specialties in 1992. Since then, various organizations such as the American Congress of Rehabilitation Medicine and the American Psychiatric Association in its Diagnostic and Statistical Manual of Mental Disorders have defined MTBI using some combination of loss of consciousness, post-traumatic amnesia, and the Glasgow Coma Scale. Concussion falls under the classification of mild TBI, but it is not clear whether concussion is implied in mild brain injury or mild head injury. MTBI and concussion are often treated as synonyms in medical literature, but other injuries such as intracranial hemorrhages are not necessarily precluded in MTBI or mild head injury, as they are in concussion. MTBI associated with abnormal neuroimaging may be considered complicated MTBI. Concussion can be considered to imply a state in which brain function is temporarily impaired, and MTBI to imply a pathophysiological state. But in practice, few researchers and clinicians distinguish between the terms. Descriptions of the condition, including the severity and the area of the brain affected, are now used more often than concussion in clinical neurology. Grading systems: at least 41 systems measure the severity, or grade, of a mild head injury, and there is little agreement about which is best. In an effort to simplify, the Second International Conference on Concussion in Sport, meeting in Prague in 2004, decided that these systems should be abandoned in favor of a simple or complex classification. However, the 2008 meeting in Zurich abandoned the simple versus complex terminology, although the participants did agree to keep the concept that most concussions resolve in a short period, and although the recovery time frame may be longer in children and adolescents. In the past, the decision to allow athletes to return to participation was frequently based on the grade of concussion. However, current research and recommendations by professional organizations including the National Athletic Trainers Association recommend against such use of these grading systems. Currently, injured athletes are prohibited from returning to play before they are symptom-free during both rest and exertion, and until results of the neuropsychological tests have returned to pre-injury levels. 3 grading systems have been most widely followed by Robert Cantu, the Colorado Medical Society, and the American Academy of Neurology. Each employs 3 grades, as summarized in the following table. Prevention. Prevention of Mtbi involves general measures such as wearing seat belts and using airbags in cars. Older people are encouraged to reduce fall risk by keeping floors free of clutter and wearing thin, flat shoes with hard soles that do not interfere with balance. Protective equipment such as headgear has been found to reduce the number of concussions in athletes, and improvements in the design of helmets may decrease the number and severity further. New head impact telemetry system technology is being placed in helmets to study injury mechanisms, and they may generate knowledge that will potentially help reduce the risk of concussions among American football players. Changes to the rules or enforcing existing rules in sports, such as those against head-down tackling or spearing, which is associated with a high injury rate, may also prevent concussions.